Good afternoon, everyone. We're glad you're joined with us today. I'm Scotty Sykes with Sykes & Company. We also have Kendall and Josh with Pioneer. Kendall is with Sykes & Company as well. We got our Master of the Margin series going on today. And today, of course, is Pioneer, and we're glad you joined us today. And I'm going to pass it on over to Josh, and he's going to take it, and we'll see what he's got for us in store today. So Josh?
Sure. All right. So basically what we're going to go over today is really kind of all the eCare plan buzzwords that you've heard from pretty much any conference you've been at the last couple of years, or CPSN, or if you look at the Pioneer webpage. I'm going to give you a quick overview of what a care plan is, why it's important, and that kind of really flows into interoperability. I won't spoil my show too much, but that just really means the ability to share common information in as close to real time as possible. And then, kind of go into the where we are now and where pharmacy is headed in terms of how does pharmacy add value to a healthcare system that's clearly going to change dramatically in the next few years. And then what are those missing components that we need in order to finish that bucket? Next slide. Just a little bit about me. I do bleed orange, and it's the burnt orange of Texas, not Tennessee. I did my PharmD at UT Austin. Went back a couple years after that to do an MBA, really focusing on healthcare reform and quality and process improvement. Just looking at the way health systems typically work, it's not known as a model of efficiency. And I kind of wanted to learn a little bit more about that. So I went in from there to working at one of the big evil empire PBMs. Followed that into a renal specialty pharmacy where I built medication management and med safety programs. And then by a stroke of luck, I ended up at Pioneer, where I could apply some of all of those things and really kind of make a bigger impact on what pharmacy looked like. Slide. All right. So whenever we talk about eCare plans where there's a small number of people that understand them very deeply and everybody else is just trying to figure out what it means, I always really like anything Lewis Carroll did, but this is always a nice piece of like, we're just about to step into the rabbit hole and see how far it goes. And the journey starts now, and this is just going to be a very topical, just looking at the entry of the rabbit hole. So we want to go deeper. There's literally thousands of hours of content out there on the internet to dig into.
Sure is.
All right, so at its core, what does a care plan do? It really just tells a story, okay? So if you think about all of the people you know and all the relationships that you have, there's a story there, right? You met your best friend in 6th grade because you were both in the same gym class, and you have this life shared experiences that go along, and they tell a story about who you are and what you are. The care plan does the exact same thing. When you look at what pharmacies do in general, you already do care plans, right? You have the same couple of patients that come in month after month, and they pick up their 10 or 12 prescriptions. You know all of their prescriptions, you know that person, you know what that person cares about, and you can look at that person each month and see, this month does Jim look better than last month? Are his numbers trending in the right direction? All a care plan does is starts to give you a structured way to document the things you already know about Jim. It also gives you a way to communicate those outcomes. So objectively, did Jim get better or worse? The way you communicate that is through a care plan. One of the things that you'll start seeing with measure bodies like the Pharmacy Quality Alliance and places like URAC, they're really starting to look toward how do you measure if something worked better than another program. And you don't get that from a PBM claims feed. right? You don't get that from a PDC. You get that from a rich story that says, I dispensed these drugs, I know about these allergies and outcomes, and I did these 5 things to make this patient healthy. And look, at the end of it, the A1C did actually go down. It's kind of a flipping on the other end of it, where everybody, the gold standard so far has been a PDC or an NPR. Did you take your drug 80% of the time or more? Well, I only care about that because it's the best measure I have today. If I can say, I don't care if you took your drug 75% of the time or 100% of the time, I care that your diabetes is under control. The care plan is the bridge to making that possible. So it's used really to do 3 main things: to measure quality of care for a patient. It's built to coordinate care. So at its core, the eCare plan is built to be able to share from one place to another without any kind of hiccups or having the patient print out 40 pages of their life story and taking it from provider to provider. This is a real-time coordination of care. And then the thing that interests everyone in this is payment. So if you want to get paid to do a service that's not directly tied to dispensing a drug, which all pharmacists want, the way you do that is to document services, what you did, why, how long it took you, and the outcome. And then inside the eCare plan, there's actually a way to translate that into a medical billing component. That part is definitively not fleshed out yet, but it is there. So we really call that, it's a bridge to billing for services. Using the care plan itself as a billable mechanism is part of the story. It's, here's the clinical information, and then I can tie a billable event to that. So that's what we're doing. Next slide.
Okay.
So the Pharmacist eCare plan was built around a robust clinical process that the JCPP is built, and I'm sure you've seen at any number of NCPA or APHA conferences. It's really that 5-step approach that's constant and cyclical. So when we look at a care plan, the first thing you have to realize is that the care plan itself is longitudinal. I don't have a care plan that lasts from Monday to Friday. That's a snapshot of your entire care plan. It's going to evolve, it's going to change. Think about a weight loss journey. If you have a 300-pound patient and you tell them they need to lose 150 pounds, I can tell you exactly what's going to happen. Nothing, right? So when you start with, let's lose 10 pounds. And when you get to 290, then you're going to lose 10 more pounds. And so the eCare plan is constantly evolving. You figure out what you need to do, you assess the problem, you make a plan, you do it, and then you make sure you can adjust that plan in a different way. So every single time you send someone an eCare plan, the way that's structured is you're going to get a snapshot in time of what it looks like from the beginning of time to now. It makes the content big and robust. It also means printing them out after a couple of years is not the way you want to go about doing it. It is meant to be an electronic exchange. But that also means that when we have these really powerful machines and systems, pharmacy or health system, you can take that whole file and consume pieces of it that you need. So it's really important. And what makes that important is it should be structured. If you think about the care plan itself is going to have health concerns, your conditions, your drug allergies, patient goals, what that patient should accomplish, your A1C from 13 to 10. And your interventions are things that you do or will do to that patient to get to that goal. So if your goal is to reduce the A1C, your interventions may be to do a diabetic education and training. It may be to go over some nutrition plan that they have, and it may be to optimize their medication. That may be switching from metformin to something like Byetta or one of the newer drugs, or back and forth. The next important piece of that is when you consume those things, they have to be structured. And structured means that they are interoperable. So if I tell you that I provided a patient a vaccine, okay, which one? Where did I do it? Did I abbreviate it vaccine? Did I call it a vax? Did I call it a vaccination? All of those things in the way humans talk make it really hard for computers to understand. So behind that, there's a backbone of interoperability that says when I put in a vaccine, every other system in that ecosystem knows what I meant. Next slide. All right, so we talked about the eCare plan being structured and longitudinal, and it contains certain things, right? So this is the kind of menu of items that are on an eCare plan when you send it from your pharmacy system to anybody else. Right now, that pretty much means you're sending it from a pharmacy system to CPESN. But in the coming months or years, you'll be seeing those being sent to other pharmacies, other doctors, third-party payers, anybody. So you're exchanging this information in pretty much real time. A system that's going to be kind of like an EHR or like Pioneer will send the things that the system already knows and compile it. And the only thing the pharmacy is going to really have to add is making sure they're updating the allergies and health conditions, getting updated labs or vital signs, immunizations. We're going to take care of the active medication list and the fill history. And then the pharmacy is going to fill out their goals and interventions, right? So otherwise, the system itself is dynamically managing those pieces, bundling them and sending them off. And then the pharmacy is really doing the clinical work and providing that clinical documentation. So that really falls into your goals and your interventions. And eventually, you see assessments down here with my fancy asterisk. At some point in the near future, what you want to be able to do is when you ask a patient a question, pharmacists do it all the time around depression rating scales, quality of life scales. Today, they're kind of like, all right, the quality of life today was a 5. Okay, great, you're measuring it. That's the first step. The next step in that is to take those questions and say, here are the 5 questions I asked. They're tied to a SNOMED code, which we'll go over in a moment. And the answers are tied to a SNOMED code as well. So what I can do is that way when a computer consumes that survey or question set, I can say that your quality of life was a 5, and here are the 3 things that changed from last time we asked it, or the 3 things that may drive some other types of improvement. A lot of clinical programs have found a lot of value in asking patients their perception about their medication regimen. Surprisingly, if you ask a patient, do you think you're going to go to the hospital in the next 30 days? If they say yes, they're probably going to go to the hospital, right? So patient drivers do a lot to kind of help with perception. And these assessments can become a very, very powerful tool in both measuring that and determining what the pharmacist outcomes and goals should be.
So Josh, I got a couple questions here.
Sure.
So where do pharmacies, will this be something that pharmacies will be doing for pretty much all patients? Is this just a select handful of maybe the higher risk patients? And is this information shared with other third parties? If a patient has several doctors, is that all? Is this one big collaboration? I'm just kind of get a sense of where this is all heading, next 2, 3, 4, 5 years.
Yeah, so in at least the early phases, these are really meant for patients who have some kind of chronic conditions. Right? When you look at when CMS implemented the Part D MTM program, they had a couple of criteria around, 3 chronic conditions, 5 meds, and a couple of other things. The easy way to translate that is payers are going to pay for patients that need to be managed in a way that's not through the drive-through. You kind of slow down a little bit, chunk your drugs out the window, and go on. I am not a target patient for an eCare plan today, right? Nobody's going to want to spend pharmacist time and effort to manage, I take Zyrtec, okay? Don't have to do all of this robust management for that yet. But your pharmacists are going to start to prove their value on managing patients that are sicker and have less understanding of their medications than the normal population. So we see that this becomes very, very sick, very old, needs a lot of management. And then as pharmacists start to prove their value, you could certainly see, this coming down to managing patients who have complex medication regimens, medications that are hard to take or difficult to understand. And then some types of simple things sound simple. Who would have thought in this world I was about to tell you that managing HIV is relatively simple? 20 years ago, that wasn't true. Today, it's relatively easy to manage, but it does require making sure that the patients are staying on their medication, that they're managing their diet, managing for opportunistic infections and things like that. So not difficult to manage, but the impact of not managing them becomes very, very expensive.
I have one question also. With the eCare plans, you spoke about how it's basically being able to package, so hopefully in the future they'll be able to have a billable service. For those who are starting to use the eCare plans now, have you seen some benefits in like client relationships or the retention rate of these clients that do need a lot of management?
Yeah, I mean, CPSN's already got, 49 networks and I think 20 plus or so payers in those networks. And those payers are very interested in being able to take this information, and it's kind of like a quality report card to say, did you do the things you're supposed to do? So early on, the lift is big and the benefit is medium, but we're starting to see the momentum pick up. 2 years ago, there was 1 or 2 payers. Now there's 20 to 30. So people are definitely noticing the value of it. And as it matures, it'll just get a much, much larger value.
Yeah, this seems foundational to me for patients with these chronic conditions, and you can definitely see where this will pick up steam, I think, down the road for sure. And of course, it's got to tie in to getting paid and when to do this kind of thing, which is really kind of where things are trying to figure itself out now.
Right. Yeah.
Like.
Unfortunately, we're in a cart before the horse situation.
Yep.
No one's going to pay for it until they realize the value of it. And it takes a fair amount of time to do this well. So pharmacists, especially independents right now, where you have a world that's fairly uncertain and margins that keep getting smaller, you really have to push the I believe button to make this work well. And like many other things that pharmacy's good at now, they've been driven by independent pharmacies looking for a way to differentiate and add more value. Immunization wasn't common, and now it's expected at a pharmacy. Things like that, where I think independent pharmacies can really differentiate by showing that localizing healthcare around a common relationship like a pharmacy will provide better care. We're entering in a world where most of the disease states that we manage now are chronic diseases. You don't do that at hospitals. You manage chronic conditions incrementally over time by providing those types of primary care services, and the eCare plan does that. So I did want to throw in here on this slide where you've got a picture of the eCare plan. They'll look different from pharmacy system to pharmacy system. This one just happens to be the preview in PioneerRx. On the left, you can see the kind of main groups of things that exist in the eCare plan, all the way from demographics down to healthcare team. The healthcare team is really valuable because when you're sending the eCare plan, you could, in theory, send the eCare plan to the patient's entire book of providers if they wanted it. So down the road, it's really meant to be a health information exchange. So if I've got 3 doctors and they don't know what I'm taking, when I'm taking it, or they may not know your whole allergy list or labs, you send all that out and now you have a complete story. So really important in sharing. But this is what the eCare plan essentially looks like. It's not really meant to be printed out and handed around. I've seen some pharmacies do that. And while they're small, that's reasonable. You could imagine if I've been doing care planning on a chronically ill patient for 3 or 4 years, you're probably printing out 40 or 50 pages of paper. But you can see here where you've got your goals, when you started, last time you updated it, is the goal in progress, achieved or failed, what conditions that goal addresses, and then the interventions that go into it. What do you do to get to that goal? So you can see it's kind of a hierarchy of goal and then multiple layers of interventions. Next slide. All right, so you know the value of the providing good clinical service, right? That's never been a doubt or even a shadowy area in pharmacy. But now we're kind of getting into that nebulous area of interoperability. So here's kind of my slimmed down version. If you go to the Office of the National Coordinator, they've got tons of pages on interoperability, but nuts and bolts, it allows different pieces of the ecosystem to speak the same language. You know, think about how important it would be if medications didn't have an NDC code. How do you know that lisinopril 10 milligrams is equivalent to lisinopril 10 milligrams? The NDC is what links that, right? And the system can say these 2 things are the same. We have other areas like doctors are linked by an NPI or a DEA. That allows the system to be interoperable. This takes the care plan to a different level where you're not only linking drugs by NDCs, you're linking allergies by SNOMED codes. You're linking health conditions by SNOMED codes or ICD-10 codes. So you're really making this as a bundle. When I send it from Pioneer to your EHR system, that EHR can consume it instead of just printing it out as a PDF that no one's going to read. So the next bullet is really important. Seamless and timely. It needs to go from one place to another without causing any kind of consumption problems, and it can't be done 6 months later. The ideal is closest to real time as possible, and you want to use usable information. So that means if I send you, I provided Josh a flu vaccine in his left arm on Thursday at 11 p.m. or 11 a.m., that you don't have to have some human translate that. The machine should be able to take it, consume it, and put it into the record. And these are the types of things that interoperability we think can drive, right? So improved care overall, so better coordination. This started with health information exchanges, 10 years ago now. Being able to kind of put all of your patient information in a usable space. What we've lacked up until recently is the eCare plan to be able to move it about in a way that was easy and a secure way to move it about, right? Nobody wants to have all of their information sitting in a single repository that's open to attack. So different security measures, things like blockchain, all kind of come into that to make having your information in a place not super dangerous. We're looking for increased or decreased administrative burden. You don't want to have to pay an army of people to read care plans and retype them back into a new system. And at the end of it, and very timely for coronavirus, improve public health data. So you want to be able to report things like vaccines to public health databases. You want to be able to pull down what a patient has. And imagine if you go to a hospital and you're not conscious and you're on your own, being able to pull down your entire medical record in a single, just go to a place, grab it, and you're good. It dramatically changes the amount of fraud, waste, and abuse that goes into the healthcare system. It helps prevent unnecessary services. And it helps prevent patients from getting medications or treatments that they don't need or potentially harmful. Next slide. So keep in mind, this is about as topical as you can possibly get on an interoperability review. So we look at how it's organized. At least it has a very structured hierarchy, but you want to, at the top of that list, you have a standards development organization. Most people have heard the buzzword HL7. It's just the standards development organization that handles a lot of the, what's the format, how's the standard developed, getting that kind of community approval of this is how we're going to do a certain thing. The content standard is the next layer. So what we have is the kind of content standard is called a clinical document architecture, sometimes abbreviated as a CDA. Basically what that was is like, if you think about, you have a spreadsheet and it has certain areas, certain fields in that area, the CDA is basically saying this is the content that goes on this sheet. And then one layer down, you have terminology. So these are your linking terms, right? So SNOMED CT is a open source international standard to say, how do I know that type 2 diabetes is type 2 diabetes across the board? SNOMED CT actually links all of these four together. So there's an ICD-10 to SNOMED CT crosswalk. The reason that's important is it really connects everybody to still speak the same language. Your SNOMED CT, think of that as kind of your Rosetta Stone of medical terminology. It's like 330,000 and growing terms in there. So it's just a huge repository of a way to speak the same language. Everybody knows what ICD-10s are. RX norm is the open source standard to kind of link NDC codes, and one step above those, you kind of have your proprietary first data bank or Medispan, which your GCN or GPI. Don't need to know a ton about those, but they kind of help classify drugs into drug classes or equivalent drug doses. And RX norm is the open source standard to tie all of those together. And then finally, you've got LOINC, and LOINC is a standard for allergies and lab values. So when you go to LabCorp or Quest and you get your chem panel, they're mapping all of those chemistry panels on the back end to a LOINC code, which sounds like it shouldn't be complex, but if you think about, if I get your sodium in your blood, I need to know that it was sodium. I need to know that the source was blood. I need to know which measurement system I'm using, either really the standard that America uses or the standard that the rest of the world uses, and the source. Sodium from blood is very different from sodium from interstitial fluid. So it's really kind of making sure that what I tell you I got, I know exactly what it maps to. And then the final piece is how we move that information around. So your transport standards. The rest of the world, and pharmacy included, is moving rapidly toward FHIR. So fast healthcare interoperability resources. This is the method that I believe 12 out of the 13 pharmacy vendors that can submit an eCare plan today use, Pioneer included. It is the newest standard. It's very, very flexible. It's based in XML, which aside from being alphabet soup to you guys, it's the web-based standard of being able to do this kind of stuff. It's super flexible. Everybody uses it. Any developer can use it, parse it, and develop against it. And so this is an area where pharmacy is actually ahead of a lot of the medical groups. EHRs were built on the first generation of document architecture called CCDA. It was very inflexible. And so they're on a probably 2 to 3 year march to move from CCDA to FHIR. But the moral of the story is interoperability is really, it's a hierarchy. You have your overlapping, somebody's got to develop it, somebody's got to tell you what's in it, and then you have to use a common terminology to make sure that everything is usable, and you have to be able to move it around very quickly and easily. So that's an entire world of information in one slide.
I got one question for
Sure.
the HL7 and then the clinical documents architecture. Right now, it's still ever evolving. How close do you feel like they are to kind of nailing down the standard that's everyone can stick to and use across the board?
I mean, the standard is there. The standard is there. It's really robust. Almost every single healthcare provider uses some type of CDA, and it's almost always attached to at least one of the 4 items down below. There's a couple of others, obviously, but if you look at all of your big EHR vendors, they use CDA. They all use RxNorm, ICD-10s. All of your labs, your Quest, your any of those guys are using Link. So the standards are there. Right now, the movement is really getting everybody on the FHIR transport. And believe it or not, it's easy to send out. It's really hard to consume. And the information's not hard to consume. There's just a lot of business rules about what do you do with it when you get it, right? Everybody always, there's this, and will always be this big kind of argument about who's the single source of truth. If my pharmacy sends the doctor a medication list, is my medication list guaranteed to be better than theirs? I think every pharmacist on the planet would say yes, and every doctor on the planet would say maybe, right? So there's a lot of what happens when you get the information and what do you do with it, that's still not solved, right? In a lot of the ways, the technology is ahead of the policy and regulations and things like that.
Thank you. Yeah, that's good to know.
It's interesting.
And then so kind of what can you do with an eCare plan or anything else when you get it? So looking at kind of your exchange capabilities, the little infographic on the right is just where it can go, right? You've got your primary care doctors, your labs, your EHRs, pharmacy to pharmacy, pharmacy to doctor, hospital. The exchange possibilities are pretty much limitless. So the whole deal of this is you have a couple of options with health information exchanges. You can all store it all in one central location, or you can have a distributed system where you can get it when you need it, right? And that's really kind of where the world seems to be headed right now. So if you're looking at the types of exchange, and you've kind of got your most common method in parentheses outside of that, so you've got query-based. That exists today. You can go into hospitals and they can pull up what's called a med history. They go into their EHR and they query something like SureScripts or any of the other, there's a few other products, and it'll pull down and give you your best case is a pretty good med list. So you have a general idea of what that patient's taking. That's great for emergency rooms where people come in after a trauma or unconscious. So that's probably the most used today and probably the least useful later on in the world. The next one is directed. This is kind of where we're moving to right now. So that is, I'm a pharmacy and I'm going to send this patient's eCare plan to CPSN for quality measure and for payment. And then the kind of unicorn of health information exchange is that it's consumer mediated. And that just basically means that the patients control where their data goes and when. So think about right now, when you go to your doctor, you have to sign HIPAA release forms every year, and they can say, well, my wife can view my information, and I have to sign for it. They have to give her information. Consumer mediated sharing could be, when I have an eCare plan ready, it comes to me on a secure app, and I can say, share this eCare plan with all of my doctors. It can go to my third party. And by the way, I want to delegate this ability to my wife and my grandma, right? So we are nowhere near this yet. There's a couple of places that try it. And a good example of that, right? You have your Epic, like my chart. When you log into your health information portal, you can do some of that. But that goal eventually is to have patients and their caregivers as an equal part of that ecosystem, to say, you probably can't control me being able to send your eCare plan from me to your insurance if I'm going to bill your insurance for paying. But you can certainly say, I want to share this with other doctors without introducing, HIPAA or other types of privacy problems there. Next slide. All right, so we kind of covered what's in an eCare plan, what's interoperability, and then starting to think about where we see pharmacists adding value. I'm one of those people that I don't think you have to have a doctor of pharmacy to be able to verify a product, right? We're moving to a place where either technicians can do product verification or computers will be able to do it with AI. You got a doctor of pharmacy, you're a strong clinician. I don't think that means immunizations. If you go to the doctor, the person who gives you a shot in the doctor's office is usually the medical assistant. So a lot of those kind of mid-level pieces can be offloaded, and pharmacists can start adding value through care plans and the next level of those things, right? So chronic disease management, I look at that as managing doses, mitigating side effects, going over medication safeties, reviews with patients, to talk to doctors and say, here's the patient, here's their goal, and if we change this medication to another, or we change the administration time, you're going to get better outcomes. And who better to make those decisions about medications when the patient's already been diagnosed than pharmacy? Discharge management has been a place where healthcare has been a disaster for a long time. There's that change of, when you're discharged from the hospital, you need to see a doctor within 7 days. Well, the reason for that is, when you leave the hospital, you leave with the best idea of what they know. And you want to have your normal doctor follow up and make sure that they didn't send you home on duplications of therapy, that there wasn't a misunderstanding in your discharge notes. Again, this is an area where pharmacists add a ton of value, because they're going to prevent those readmissions in hospitals. Antimicrobial stewardship, another one, making sure that we're not just going crazy on antibiotic use and using the right ones. Quality is huge. You look at the healthcare system and you realize we spend more per capita than any other country on the planet, and our quality is decidedly mediocre. Part of that's going to mean that different people in that health ecosystem have to work together to make sure their quality is good. Today, doctors are measured on a different set of quality standards than pharmacy. And being able to share that information back and forth may mean that we can make sure the quality is there, and everybody who does the work gets credit for it. So today, a pharmacist does chronic care management on behalf of a doctor. The doctor can get credit for it, but the pharmacy has to have a kind of defined relationship with the doctor. Once the regulations catch up, that doesn't necessarily mean that any pharmacist couldn't do it. So there's a lot of areas where we can really add real defined clinical value, and we need to be able to share that information readily to do that. That is an area where Western Europe does well in their healthcare, at least on their quality and spend in the primary care sector, because pharmacists do a lot more work like this.
And this, again, this seems foundational to me, Josh. To me, it seems like this should be going on for years now, and it's just kind of just now starting to really come out. And of course, you know, pharmacies aren't really getting paid for this yet, and
Mhm.
hopefully, you know, that changes sooner rather than later.
Yeah, I mean, the good news is, I mean, if you look at states of change in the country where we've had rapid changes, almost always for the better, are those periods right after things get really bad. You know, like we had a massive industrialization and improvement in defense technology in the first 2 years of the World War II because the Japanese armies and air force was just dominant in the Pacific. So we did crazy stuff like develop radar and anti-tank weapons and things like that because we didn't have a choice, right? And we're at a point now where healthcare is so expensive and somewhat inaccessible to a lot of people that we're reaching a point where we don't have a choice and somebody's going to have to do something crazy. And pharmacy's positioned well to do something crazy because we also are in a boat where we don't have a choice. You can't live off of no margins. And so you have to find a way to differentiate and add value. And it just so happens that I think the pharmacy profession and the healthcare system actually are finally starting to be aligned in what's important. At
Yep.
least that's my soapbox and my dream.
Yeah, it seems to me now that they have the foundation there, the standards are there, the technology is there. It's just a little bit of an investment of time that you're already investing in if you are really active and proactive, just to document what you're already doing. And when the time comes, it could be overnight where this interoperability starts to fire off. You'll be there to have everything ready to profit
Right.
from it monetarily and to help right now whoever your patients are that you're seeing. That's the
Right.
way. That's the way I'm kind of gathering information.
Yeah, and our goal, right, when the care plan first started, everything was manual, right? You had to double enter a lot of things. You had to enter the goals in very specifically. And the real push that Pioneer's done in the last 2 years really has gone from how do we automatically start the right care plan when you need to? How do we autofill the stuff that you don't need to do over and over again? And how do you make it as simple as possible for a pharmacist to document the things they're already doing and prove that value? One of those examples is we recently automated the MedSync care goal. So when you're doing your normal med synchronization with the patient, you're already checking, you're calling the patient to find out what they need. You're identifying any potential problems while you're talking to the patient. And then as you fill those drugs, we're putting all of those onto a care goal. We're taking the sync notes that you talked to the patient about and dropping that into the care actions note. And then when the patient picks up the medications, we're automatically submitting that to whoever needs to get it. That doesn't mean the pharmacist did any less work at all. It just means that we've appropriately documented the work that they were going to do anyway, right? That's the first step to proving value. So when you go to CMS or your state or even your local employer and say, I think I'm worth 50 bucks a month to do this type of work, or $15 per member per month, whatever it may be, you're going to do that work and they're going to see at the end of it, you've got all this rich data that they didn't have before. And then they can figure out why your patients are healthier than going down the street to, random big box pharmacy.
Yep.
There's clear difference in appropriate clinical management for chronic patients.
Yeah, clearly technology like Pioneer is critical in this area without a doubt. But yeah, going back to the theme here of this type of management and the pharmacy kind of evolving. We haven't, since we've done these Master the Margin series, we haven't really talked about filling scripts on any of them. It's all about, what's the pharmacy of tomorrow looking like, and that tells you a lot right there. That's where a lot of the focus is on, just in overall for pharmacists out there.
Right. Yeah, I mean, really, with as many drugs are generic as they are today, and then the ones that aren't generic or specialty and limited distribution, like I don't think any independent pharmacy wants to be in a race to sell a commodity. Right? There's no margin in that.
Yep.
And so being able to do these types of things makes it a whole different world. I don't think pharmacists are ever going to be in a place where dispensing a drug isn't something that pharmacists do, but that shouldn't be how the pharmacist makes their money, right? They should make their living off of providing clinical services to patients, and that's where the eCare plan's headed. That's where technology's headed. We just have to get the healthcare system to catch up a little bit.
That value add, yep.
Yep. And we kind of already accidentally talked about the last page here. Like a couple of areas where pharmacists can prove their value. The downside is a lot of them are going to have to do this without getting paid for a while. Insurance companies are notoriously conservative about not paying for something until they absolutely have to. And even then, sometimes they're not great about paying for stuff. We mentioned a little bit updated laws and regulations, really making those CMS regulations agnostic to who provides the service. It doesn't make sense for a doctor to do a medication safety review. That makes all the sense in the world to have that done on a pharmacy. They just don't right now because a physician can get paid for it and a pharmacist can't. And same kind of deal on those collaborative practice agreements. I think you're going to start seeing a lot more CPAs in the pharmacy world. Independent providers have the same kind of market pressures that independent pharmacists have. So it just makes a ton of sense for those two groups to kind of join together in a kind of a virtual ACO, if you will. Let's divvy up the right resources to the right provider. And the only goal there is to make sure everybody's happy and healthy and patients get the right care that they need. And,
Yeah, I agree on that. Good stuff.
And that's it for me.
That's all we got. All right. Well, let's see. RX assessment service. If you got questions, I'm going to go ahead and say if you got any questions, go ahead and throw those in the chat box or the question box there, and we'll pass those on to Josh and see what we can answer there. But on the screen here, we have the RX assessment service. This is what we do at Sykes & Company here. We do offer a service if you have questions on your accounting or tax information, you're not sure, maybe if your books and records or your tax situation, you're maximizing that. This service is something we offer. We take your accounting file, your tax returns, we overview that internally, and we get you on a video call and we give you feedback on exactly where you stand from an accounting and tax perspective, what opportunities we see, what issues, concerns, etc., and kind of give you a roadmap of what it is you need to work on from an accounting and a tax back office standpoint, and get you on your right feet there. So we do offer this service. You can go to our website and check that out. Just a quick disclaimer there. You can always ask us any questions at AskSykes at sykes-cpa.com at any time. We can answer those as well. But let's see, let's go to the questions here. Josh, suggestions on learning how to complete an eCare plan and implement daily workflow. Any suggestions on that?
That'll depend a little bit on the system you plan on using for eCare plans. One of the things that Pioneer spent a ton of time on was making sure that the eCare plans incorporate into your workflow. Right, so you can complete a care plan while you're dispensing a medication. You can have a back office pharmacist do it. There's a million different options, like almost everything else in Pioneer. If you're using a system that's kind of a bolt-on to another pharmacy system, so say your pharmacy management system doesn't have native care plans and you're using a service like Prescribe Wellness or Omnisys Strand, it's going to be a little different in those cases. A little I guess, a more disparate workflow. But as far as the Pioneer side goes, I can speak to that more coherently. We have a really robust set of training programs on our Pioneer University. You can watch multiple videos. We have them broken into 3 sections about how to use basic care plans, a second section for an intermediate user on how to build them, and then a third section for your advanced user on how to automate them and kind of build custom cohorts for those care plans. The other part is, you can always use your account manager, ask them questions. The easiest way to do that, though, is to start with one thing. Like with MedSync, you start out with 5 patients and you figure out how to do that, and then you add 20 more, and then so on. The next thing you know, you've got 80% of your patients on MedSync. When you start with care plans, start with that one group of patients that you want to hit. Maybe that's your patients who are on HIV meds, or grab patients who have a rescue inhaler but don't have an inhaled corticosteroid, or vice versa. So you pick a very narrow band of people to work with, learn how to do them, and then move on to the next one.
Looks like that's all the questions we got here, Josh. So I guess we'll wrap up our presentation today, but we certainly appreciate Josh and PioneerRx joining us today. And again, if you got any questions, ask Sykes at Sykes-CPA, and we'll answer those the best we can or pass them along to Pioneer. But we certainly appreciate everybody joining us today, and of course, Josh and Pioneer. And there will be a replay of this for those listening now on our website, and you will get a copy as well. So thank you to everybody, and we'll see you next time.
Great.
Thank you, Josh.